Okay, good afternoon, everyone. I welcome all one for this course on ocular burns. So we all know that ocular burns are one of the two ophthalmic emergencies, and only ocular condition where history taking and examination should be delayed and start immediate management without waiting for proper assessment of the injuries. There should be coordination with physician, surgeon, and psychiatrist. And you should also remember that bilateral chemical exposure is especially devastating, often resulting in complete visual disability. So proper management in the acute stage is most important, and that determines the long-term outcome. And if we don't manage them properly, then we have to manage the sequelae. And the long-term damage to the ocular surface is mainly because of chronic inflammation, often causes fibrosis and continues to cause damage to the conjunctival and limbal stem cells. Subconjunctival fibrosis leads to symblepharon formation for initial shortening and entropion formations. Goblet cell deficiency results in abnormalities of the surface mucous secretions, and this also contributes to the poor tear function, and that further worsens the ocular surface in these patients. The course outline is that in ocular burns spectrum classification, and its overview will be talked by Dr. Aditya Pradhan. Medical management and of these chemical and thermal injuries will be dealt by Dr. Aditya Bajaj. I will be talking on the role of AMT, tendonoplasty, slate, mucous membrane grafting, scleral patch graft in acute chemical and thermal injuries. Late visual rehabilitation in unilateral ocular burn cases will be talked by Dr. Paras Mehta, and for bilateral cases, late visual rehabilitation will be talked by Dr. Soham Basak. So now I invite Dr. Aditya Pradhan to talk on the spectrum classification and overview. Over to you, Aditya.
Good afternoon, everybody, and thank you, Dr. Tuhin,
Actually, somebody has to be paid in the last moment.
6 is the most severe, it has the most poor prognosis, where all the limbus is involved and the conjunctiva is also 100% involved. So, if you compare the prognostic value of overall and the DUA classification systems, so DUA is obviously superior because it offers 2 more grades, and the overall just stops at 4. So, you get a better idea of the prognosis and the outcomes. And this is introduced from Shankar Medical at Chennai, in which they have an online system or calculator
5 आदमी तो आ गया.
but we are getting there. Thank you so much.
Nice talk, Aditya. So you have done a wonderful job on how to classify these ocular bonds. So now this management part, this medical management will be talked by Dr. Aditya Bajaj. In the meantime, if you have any questions, you can ask also, or we can discuss also. करा लिया मैं. सोम ज़्यादा कुछ नहीं बोलेगा.
Good afternoon, everyone. Thanks, Dr. Tuhin Chowdhury, for including me in this IC, and thank you, AIOC. I have no financial disclosures to make. Ocular chemical injuries are true ophthalmic emergencies that require immediate and intensive intervention to minimize severe complications and profound visual loss. These severe complications occur due to a non-healing corneal epithelial defect in the acute stage and in worse situations leading to corneal perforation and glaucoma. The presence and extent of epithelial defect is the one effect of the chemical injury that determines the severity of the injury, the various sequelae that are to occur, and the severity of inflammation. In other words, inflammation and epithelial defects are mutually inclusive factors that determine the final outcome. Hence, the primary aim of the initial medical management is to re-epithelialize the ocular surface. So the first step is the removal of the inciting agent, and copious irrigation is the first step with available water at site. That is the first step which is to be followed. And the goal is to normalize the pH to less than 7.4. Once the patient is in your clinic, the most commonly employed solution is ringer lactate in the hospital setting. And you can use the pH paper shown in this picture to determine the pH. Roughly, it will show the pH. Never neutralize an acid with a base, as it causes more damage. And in cases of Lyme and Chuna injury, an examination under anesthesia is mandatory in children, especially looking for the stuck particles in the fornices. Some suggest paracentesis and removing an aliquot of aqueous and reformation with buffered phosphate solution, and it can lower pH by about 1.5 units in case of alkali injury. Diphoterin is a proprietary amphoteric solution and it has been heralded as a universal emergency irrigant, but it is not available right now with us. So these large chunks of Chuna, they have to be manually removed with forceps, either in the clinic itself or ideally inside the OR. Alternatively, it can also be loosened by irrigating first with a low molecular weight EDTA solution. Next comes the control of inflammation, and topical steroids in the first week to 10 days is the mainstay of therapy. There is a risk of accelerating the sterile melt beyond the first 2 weeks if the steroid is continued. But stopping steroids at this stage can be equally detrimental to the process. So if steroid has to be continued beyond a period of 2 weeks, then it should be combined with a amniotic membrane grafting along with a bandage contact lens. And then we can safely continue the steroid for more than 2 weeks. IOP rise can be treated with topical alpha or beta blockers, and sometimes oral carbonic anhydrase inhibitors may also be required. In rare cases, a beveled paracentesis may be required for urgent lowering of IOP. But you should also assess for steroid responsiveness in the follow-ups. Lid position and periodic blinking required to resurface the cornea with tears are usually disturbed even in mildest injury. So non-preserved tear substitutes are required for symptomatic relief. A strong mydriatic should be given to relieve the ciliary spasm, and you can also give a prophylactic antibiotic eye drop for a week or so. For pain management, a temporary bandage contact lens may be applied. Although pain is severe in the initial stage, it is very short-lived because of the destruction of the pain receptors. Oral NSAIDs can be given, but you should avoid topical NSAIDs. And for the photophobia, you can prescribe dark glasses. There is a role of ascorbate, and because the tissue characteristic is, it's a sine qua non of a localized tissue scorbutus. So this ascorbate deficiency, what it does is it causes a faulty repair process, and it tips the destruction to repair ratio towards the destruction. And that leads to progressive stromal melt and finally corneal ulceration. So 10% topical ascorbate and 1 gram of ascorbate orally per day till the time of reepithelialization can be given. The transitional stage of medical management begins from 1 to 2 weeks in mild injuries, and in severe cases it starts from one or 2 months. Persistent epithelial defect is one major cause of concern, and it is due to poor limbal stem cell health, and that leads to poor inflammation and exposure, and also due to poor blinking. At this time, drug toxicity is an important cause of persistent epithelial defect. Preservatives such as benzalkonium chloride and ointments containing lanolin can perpetuate or even create new epithelial defects. So it is wise to avoid topical treatment with multiple medications in hopes of preventing corneal ulceration. Cysteine and acetylcysteine are both effective inhibitors of collagenase, and acetylcysteine is readily available as mucomist 10% or 20%, and it should commence 7 days after the injury. For persistent epithelial defects, autologous serum eye drops have been rediscovered as a method of establishing epithelial integrity. It can be used 2 to 3 hours, every 2 to 3 hours initially, reducing to 4 times a day, and only stopping weeks after the defect has disappeared. And failure of epithelialization at this stage also, that means that the stem cell deficiency has ensured. Citrate acts as a chelator of extracellular calcium, which is located in the plasma membrane of neutrophil, and it can entirely halt virtually all neutrophilic activities. So hence it prevents corneal ulceration. There are some newer alternatives like fibronectin, albumin eye drops, and epidermal growth factors. They all enhance the rate of healing and hyperplasia of the corneal epithelium. So there are a few sequelae to non-healing epithelial defects like corneal melt. In these cases, a repeat amniotic membrane grafting can be undertaken for progressive thinning as well as early melt. Oral doxycycline 100 mg twice daily, then once daily, along with tetracycline ointment can be given. These are again effective collagenase inhibitors, and a corneal perforation should then be addressed based on the size of the perforation using a TABCL with or without a Tenon's grafting. Lamellar or tectonic keratoplasty along with measures to address the other factors may be also required in certain cases. So in summary, no effort should be spared in the management of acute chemical injuries. Primarily efforts have to be made to restore epithelialization as a means to reducing further sequelae and on abating the associated inflammation and reduction of the intraocular pressure. Unaddressed ischemia and exposure will cause non-healing defects and corneoscleral melts, and providing an alternate source of cells in an eye with a severe grade injury is of paramount importance. Finally, a limbal epithelial transplant may be required along with a lamellar or a full thickness corneal graft. Thank you.
Thank you, Dr. Aditya. It was a wonderful overview of medical management of acute chemical injury. Now we move on to our next speaker, Dr. Tuhin Chowdhury, who would be talking to us on role of amniotic membrane tenonplasty / scleral patch graft in acute chemical and thermal injuries. So essentially, he would be talking to us what surgical manipulations can be done to protect the cornea in acute chemical injuries. Over to you, Dr. Tuhin.
Okay. So I'll be talking on the surgical management. So role of tenonplasty, slate, scleral patch graft, MMG, all these things. So first of all, he has already told that we have to promote ocular surface healing. So to reepithelialize and to control inflammations of the ocular surface, it is most important. We have to address the scleral ischemia and exposure of the ocular surface, and these are the key challenges. And in both the cases, for acute and both chronic cases, we have to manage that way. So this is ischemic part, and there is the exposure part. This tends to be addressed very properly. So surgical therapy that to promote epithelial healing, we have to go for either amniotic membrane transplantation. In some centers, in some practices, if they don't have amniotic membrane, they can put large diameter bandage contact lens, 40 to 16 millimeter. Sometimes in presence of ischemia, we have to go for this tenonplasty, or sometimes we may go for alloslate, that or cadaveric alloslate, that means, or sometimes we have to go for conjunctival transplantation. So amniotic membrane transplantation, it is indicated only in cases grade 3 to grade 6 as per Dua's classifications. Grade 1 and grade 2, this chemical injury can be managed medically. Those patients don't need any sort of amniotic or surgical therapy. So amniotic membrane transplantation can be used as a graft where this graft is epithelial side is up, and that acts as a basement membrane for epithelialization. And it can be used as a patch where the graft, the amniotic membrane graft, the epithelial side is down, where it will act as a biological contact lens. It helps to, that means, reconstruct the ocular surface. It promotes rapid epithelial healing, and it partially restores the limbal stem cell function. This is a patient who had, that means, grade 3 chemical burn, and just after 10 days, you can see this epithelial, this epithelium is restored now. So now I'm going to this, how to go for this amniotic membrane transplantation. This is a patient, 8 years old, who had a Chuna injury. You can see this, the Chuna got accumulated in the superior tarsal conjunctiva. So there is necrosis of the superior conjunctival fornix along with this tenonous capsule. So we have to remove all those necrosed tissues along with this necrosed conjunctiva. All sorts of necrotic tissues should be removed. Then we have to go for 360-degree conjunctival peritomy. Now putting this amniotic membrane with epithelial side up. You can use this fibrin glue. If you don't have fibrin glue, then you can put a circumferential this tenonylon suture. So even in children, even if you use this fibrin glue, we have to suture it either in the at the limbus or at the peritomy sites. At the limbus, we can use this tenonylon suture. At the peritomy site, you can use this sevenovehicle suture. So this peritomy, that's congenital peritomy suture over the amniotic membrane by using 70-vehicle sutures. Then now I have to take care of this fornicial defect. So again I am putting another piece of amniotic membrane over the fornix. Here one can suture this edge of the amniotic membrane with the edge of the lead by using 70-vehicle suture. So now I have not put any sutures, only fibrin glue, and that means got support from this this conformer. And in all children, we are putting this to suture tarsorrhaphy after conformer, and that should be removed after 3 weeks. So post-operatively, I have given all those steroid antibiotics. This is the picture after 6 months. You can see there is no symblepharon formation, and there is no restriction on the ocular movement. So now, if you don't have this fibrin glue, then we can put this, use this 406 suture in the fornixial area and then suture it over the bolsters, or even you can use this prolene suture also. And in the lid margin, you can put this tenonylon suture. As Dr. Aditya mentioned that we have to go for seeing this limbal ischemia or scleral ischemia. So in presence of scleral ischemia, that is this blanched out white appearing sclera, like this here in these cases. So here only amniotic membrane transplantation won't suffice. So these patients need tenon advancements or tenonplasty. What is tenonplasty? That is this, that tenon pedicle graft is put suppose that this is the ischemic part. I am taking these tenons from this deep upper fornix and putting it and suturing it in the limbus. Okay. So first you have to just, here there is bit scleral ischemic part. So you have to cut this, you have to separate these tenons from the overlying conjunctiva and underlying sclera, and then remove that this necrosed area, cut it, those necrosed areas to be cut, and then fresh areas you have to suture it at the limbus by using 70 ficryl suture. So whenever we are just pulling it, we should not pull it too much, otherwise there will be fornicial shortening. So just to restore this, this blood circulation in the ischemic part, and it will act as a pedicle graft, and these patients will have very good results. So tenonplasty is considered as a globe-saving procedure that helps and accelerates reepithelialization of the cornea and conjunctiva through limbal perfusion. So this is a 52-year-old man who had this thermal injury 6 days ago. Patient was initially treated at Steel Hospital, and then there was a large epithelial defect, large area of scleral ischemia. So what I did that, I thought that I will put this tenons from here and then suture it here, but it is totally charred scleral tissue. So I cannot pass the suture here. So what I had to do, I have to put a piece of that amniotic membrane over this area of this scleral necrosed scleral area. So then take these tenons and then putting it, suturing it over that tenons area. Now I am taking these tenons and suturing by using 70 ficryl over this amniotic membrane. Then putting another piece of amniotic membrane over that this tenonplasty, sutured tenonplasty area, and then I put a tenonylon, this circumferential suture, and then suturing again this conjunctival defect by using again 680 ficryl. And now putting a bandage contact lens. So this patient, after 10 days, this ischemic part is getting perfused, and this is after 3 weeks. After 3 weeks, after 6 weeks, I could see that there is a large persistent epithelial defect. So at this visit, I started this patient on autologous serum 20%. So that epithelial defect is getting reduced, and this ischemic part is getting better now. And this is the picture after 6 months. So I asked this patient for this, because the patient has good bad vision, so I asked for this parental keratoplasty. Patient ran away. Again, patient after this corona came, after 2 years, this vision has improved to 636 now. So same way, another surgery where we did this, I could not put this any sort of tenon, I could not put this pedicle tenons graft over the limbal area. So I had to put this again, put this amniotic membrane, and then again put this modified tenonplasty. And this patient, so this is the initial presentations. Patient came after 30 days. At that time, patient had a central perforation. But the good thing is that this ischemic part is getting better because of this tenonplasty. So at this visit, I did this therapeutic graft, and this is after 1 day only, this therapeutic along with tarsorrhaphy. And this is after 3 weeks, you can see this therapeutic graft is well taken up. And I just lead this tarsorrhaphy, but patient came with a large epithelial defect. So again, I put this patient on autologous serum, and now after 9 months, this patient is maintaining good vision of 6/60 now. Sometimes one may have to repeat the procedure. Allo slate or cadaveric slate or oral MMG can be added. When the globe integrity is restored and ocular surface is stable, then we can plan for further surgeries. So this is a patient who had this 9-year-old boy, Chuna injury, had this tenonplasty with AMT. But at 6 weeks, you can see that there is a persistent epithelial defect along with this symblepharon formation. So what I did this cadaveric slate. And then after that, I could see that this symblepharon is also perfectly healed up, and then that large epithelial defect is also healed up. So this alloslate seems to be a useful technique to achieve rapid epithelialization in severe chemical injuries, thereby preventing the adverse effects of delayed epithelial healing. No doubt about these eyes would require a subsequent limbal autograft following a failure of the transplanted cells. But one thing should be that these patients, because of epithelialization, rapid epithelialization, these patients don't need any sort of penetrating keratoplasty. That is the only beauty of this alloslate. Sometimes this tenonplasty should be combined with mucous membrane grafting. So we all know that buccal mucosa in histology and physiology resembles the conjunctiva and is considered as a substitute for the conjunctiva in replacing sclerocorneal ulcers and sclerocorneal melts. However, pre-oral buccal mucosa doesn't have improved this local ischemia, and so should be that means added along with this tenonplasty. So tenonplasty improves the local microenvironment and microcirculation, and oral MMG provides many cells for repair, and it increases the tectonic support of the melt area. So this is the patient who had this bilateral thermal injury, and because of injury, one eye became thicycle. Patient was at DSP hospital and then came after 40 days. So at this visit, there was a large area of scleral ischemia. So I could have, if there is no ischemia, I could have gone for a banana graft. But then I thought that I will put this tenonplasty along with this oral mucous membrane grafting. So this is the picture after 1 year. So we have to address this exposure. So this is firecracker injury. So after this AMT with tenonplasty, again there was some sort of this exposure. So the exposure part was taken care by my oculoplastic colleague. So she did this cutler beard surgery. So then after that, this patient again had this symblepharon along with this vascularized panas. So what I did this, I released the symblepharon and put a congenital autograft, and this is the picture after that means 6 months only. One should remember that if there is a frank perforation, in these cases one has to go for this scleral patch graft. So this patient who after 6 days of injury came to us, so what we did this scleral patch graft. After this is the picture after 1 day, this is after 3 weeks, and after 2 months, after 1 year, you can see that this is now doing perfectly fine. So these patients need close follow-up after the initial injury for management of possible sequelae. Corneal ulceration or perforation may be there. Corneal scarring with limbal stem cell deficiency may be the sequelae. We have to closely look at these patients for secondary open angle glaucoma, conjunctival scarring or symblepharon. And these patients may develop dry eye, and there may be exposure due to lid malposition from cicatricial changes. So to conclude, proper management in the acute stage is the most important, and that determines the long-term outcome. When the globe integrity is saved and ocular surface is stable, one can plan for further surgeries, and based on severity, there are many options. So now Dr. Paros will be talking about these unilateral cases, how to visually rehabilitate them. Over to you, Dr. Paros.
Thank you, Dr. Tuhin Chowdhury, for this comprehensive coverage of role of AMT, tenonplasty, slit, and scleral patch graft in acute burns. Thank you. I now invite Dr. Paras Mehta to talk on late visual rehabilitation in unilateral ocular burn cases by different modalities.
Good afternoon, everyone. And at the outset, I would like to thank the AIOS Scientific Committee as well as Dr. Tuhin for making me part of this interesting instruction course. I would be talking to you about late visual rehabilitation in unilateral ocular burn cases by different modalities of treatment. But before that, I would like to just add one more point to Dr. Tuhin's talk, that you should have a very low threshold for tarsorrhaphy in those cases where you see persistent epithelial defect despite your medical management or a surgical intervention in acute thermal as well as chemical injuries. That works very well if you don't have an access to autologous serum or other things. That is something which you should always keep it in your armamentarium. So I need financial interest. Unilateral chemical burn sequelae could be in the form of pannus formation, symblepharon, corneal stromal scarring and thinning, fornical shortening, restricted eye movements due to subconjunctival fibrosis. There could be total or partial LSCD development, or at times keratinization and loss of an eye. So, we need to decide the strategy to tackle these issues, which may be directly involved with visual and functional outcomes. Before we embark upon that, let us have a look at the basic thing. The limbal stem cells are responsible for the regeneration of corneal epithelial cells and the maintenance of the integrity and transparency of the cornea. Within the limbus, the limbal epithelial stem cells are thought to reside in a stem cell niche which maintains them in their undifferentiated state, and this stem cell niche is the palisades of Vogt, which are thought to provide a protective environment for the limbal epithelial stem cells. A characteristic of these cells is that they are normally slow cycling but have a high proliferative potential, and they are thought to divide asymmetrically, forming a stem cell and a transiently amplifying cell. In this way, the stem cell population is maintained and the transiently amplifying cells can divide to form terminally differentiated cells which can maintain or replace the tissue in which they reside. It is possible that limbal epithelial stem cells are capable of both symmetrical as well as asymmetrical stem cell division dependent on the need. The destruction of the limbal stem cells or the stem cell niche or both leads to limbal stem cell deficiency. And this deficiency results in delayed epithelial wound healing, as it was alluded upon in the previous talk, recurrent epithelial erosions and loss of vision. Here you can see these clinical pictures having limbal stem cell deficiency due to various reasons. But in this particular talk, we will be focusing on chemical injury. So clinically, limbal stem cell deficiency is characterized by conjunctivalization of the cornea or pannus formation, recurrent epithelial breakdown and inflammation of the ocular surface, and loss of transparency of the cornea leading to impairment of the vision. These are the various causes of limbal stem cell deficiency. We may not go into the details of that, but if you look at this diagram, it just talks about that in unilateral the chemical injury makes the majority of the portion of unilateral limbal stem cell deficiency. So here we will be talking about that. A corneal transplantation alone is ineffective in limbal stem cell deficiency, as it results in recurrent epithelial breakdown, surface healing issues, and ultimately graft failure. Fortunately, limbal stem cell transplant can restore the normal epithelial phenotype and re-establish a stable corneal surface. We must understand that conjunctival and corneal epithelium is having a different phenotype. So if you have a conjunctival epithelium onto the cornea, definitely that surface would be unstable. In patients with unilateral limbal stem cell deficiency, the healthy fellow eye can serve as the source for donor limbal tissue, which makes the procedure autologous, and it also obviates the need for any systemic immunosuppression. You can see this in these clinical pictures that there are examples of partial limbal stem cell deficiency. You can see a pannus formation or a conjunctivalization, as well as a 360-degree limbal deficiency where the whole cornea is covered by the conjunctivalization. If you look at the algorithm for management of the limbal stem cell deficiency, we can, the most important part here is primarily to control the inflammation before you embark on providing the limbal stem cells from any other source. Once the inflammation is controlled, you look at whether you are dealing with partial limbal stem cell deficiency or you are dealing with total limbal stem cell deficiency. Here we would be focusing on partial limbal stem cell deficiency. So So if the patient is asymptomatic, only a medical management would be sufficient enough. You can put the patient on lubricants, or maybe intermittently whenever there is a need, they can be put on topical soft steroids. If these patients are symptomatic, there are various other options available. You can repeat an amniotic membrane transplant, or what Professor Dua described is sequential conjunctival epitheliectomy can be done, or an ipsilateral limbal translocation can also be done. If it is unilateral but with a total limbal stem cell deficiency, the other options are conjunctival limbal autograft, or SLET, or CLET. So techniques of limbal transplantation, or also it is known as limbal epithelial stem cell therapy recently. The previous strategies to correct limbal epithelial stem cell failure include transplantation of limbal autografts from the healthy fellow eye, or limbal allografts from a donor. Both have drawbacks, including the potential creation of limbal epithelial stem cell deficiency at the donor site of autografts, or the requirement for long-term systemic immunosuppression in cases of allogenic tissue. So let's look at CLAO, or conjunctival limbal autologous transplantation. In this particular procedure, essentially 2 grafts are taken of 2 clock hours area from superior and inferior limbus, along with the adjacent rim of conjunctival tissue from the patient's other fellow healthy eye. This procedure has the longest track record and has been shown to successfully restore the corneal epithelium in approximately 75% of the cases. Unfortunately, CLAO is known to be associated with complications like risk of developing iatrogenic limbal stem cell deficiency into the donor eye, and sometimes there may be a granuloma formation at the donor site. The other technique which was popularized was conjunctival limbal epithelial transplantation, but Pellegrini et al. In 1997 described cultivated limbal epithelial transplantation. They took about 2 by 2 millimeter limbal biopsy, and from the donor eye it was expanded ex vivo in the laboratory for 10 to 14 days. So you need 2 weeks time to expand it into a sheet of epithelial cells, and then it was transplanted onto the surface of the affected eye. But definitely the downside was this requires an elaborate lab setup. Then in 2012, Dr. Sangwan and group described the technique of simple limbal epithelial transplantation, which is popularly known as SLET, where a strip of donor limbal tissue from the superior limbus is obtained from the healthy eye, and it is divided into small pieces, approximately 8 to 10 pieces or sometimes 12 pieces, and it is transplanted directly onto the affected cornea after removal of the pannus for in vivo expansion over a human amniotic membrane graft instead of ex vivo expansion in the cleft. So these are the steps. So, and there were multi-central studies which also proved that this technique is much better. If we compare conjunctival limbal autograft versus CLAT versus SLET, autologous limbal stem cell transplant for unilateral limbal stem cell deficiency showed anatomical and functional success rate of 69% and 60% respectively, without any serious adverse events in the donor eye. The anatomical and functional success rate of SLET was 78% and 68.6%, and CLAO was 81% and 74.4%. Both were comparable and significantly better than those of CLAT in this study. So then it was, even the economical aspect was compared. The results of economic analysis suggested that SLET provided a much lower, it was much cheaper and economical as compared to CLAT. There were several variations also described by various people. Some people use customized SLET for localized limbal stem cell deficiency. Even a sandwich technique was popularized, where 2 layers of amniotic membrane, where the explants were covered also by an amniotic membrane. It was combined with conjunctival autograft. It was also combined in some cases with a mucous membrane graft. And very recently, a recent paper talks about SLET directly applied on bare corneal surface without putting the amniotic membrane graft over the bare stroma. Just to simplify this, if there is conjunctivalization of the peripheral part of the cornea and it is a partial limbal stem cell deficiency, there is no need for SLET. We don't have, SLET is not a panacea for everything. One can just do away with conjunctival autograft in this situation, and you can add tarsorrhaphy depending on what is the level of the involvement. If there is a conjunctivalization of the peripheral cornea, plus there is a corneal, central corneal superficial stromal haze, maybe probably you can take a call here And you can do either a conjunctival autograft along with SLET. And again, tarsography is based on the clinical presentation. If there is a total limbal stem cell deficiency, as you saw in previous clinical pictures, but not much of a central scar, then probably SLET is a good option and with or without conjunctival autograft, depending on how much is the involvement of the limbal tissue and what is the level of conjunctivalization of that particular cornea. And this is a pictorial representation of the same which I talked about, that where we can do a SLET and where we are not supposed to be touching or doing any SLET, and where we can do, if there is a symblepharon, probably we can do a SLET and CAG in those cases. So let's look at clinical case scenarios. This was a patient of bilateral acid injury, responded to, this is just one eye of that patient. He had a bilateral acid injury, responded to bandage, contact lens and medical management initially. But later, couple of months later, he presented with localized LSCD with recurrent redness episodes due to recurrent epithelial breakdown, as you can see here in these clinical pictures. And yeah, as I alluded upon earlier, like these are the cases where you don't need to SLET. Like, you can't, you can do away with just a conjunctival autograft. So he underwent a pannus resection, and like a pterygium surgery, you can do a conjunctival autograft, and here the area was much smaller, so we used the conjunctival autograft from the same eye. And you can see the results that the eye is much quieter and he has become asymptomatic and the vision has also improved. This is another example where this patient had like pannus resection with conjunctival. This patient had previous acid injury and he had undergone amniotic membrane graft and tenonplasty earlier and maybe probably a tarsography. Later on he presented with pannus in that localized area, but the area of involvement was much larger. And that's why we ended up doing a conjunctival autograft. We also took some amount of limbus along with to provide limbal stem cell to that area. And you can see the results are very good. His vision improved from 624 to 69, and we also did a temporary tarsography which helped stabilize the surface, which can be opened up after a few weeks depending on how the ocular surface is behaving. This is the surgical procedure which we did for that particular case. We just removed the pannus from the surface. This was little easier because previous amniotic membrane transplant was done. Then it is easier to find a plane. If somebody has handled these cases early on, in the acute phase, it is a lot more easier to find the plane and do a procedure. So it is very important to have a primary management in place, and then the secondary reconstructions become a lot more easier. So here you can see that we are reflecting a conjunctival graft from the fellow eye. Because this eye also had probably an injury, and that you can see that we have taken a larger graft to cover that area of pannus, and a fibrin glue is applied, and the graft is attached in the area of bare sclera. But here you have to note that you keep this graft little away from the cornea or a limbus, at least about a millimeter away, so that you want the corneal epithelial cells to cross over rather than the conjunctival epithelial cells. These are other examples of a similar thing. A 10-year-old male child presented with Lyme pest injury. He developed a symblepharon. As you can see here, there was a restriction of eye movements, also the upper lid. And he underwent just a symblepharon release with a conjunctival limbal autograft because it was a child from a fellow eye, and his visual acuity improved from 660 to 612 part, and later on he was fitted with a contact lens and he improved to 6.6. This is another example where there is a lot of inflammation. A 28-year-old male who sustained Lyme paste injury. He had undergone tenonplasty and amniotic membrane twice elsewhere. He presented like this to us. You can see that the lower lid is also adherent to the bulbar surface and the eye is pretty inflamed. You need to control this inflammation first before embarking upon the reconstructive surgery. So this is the surgical video of the same patient. As you can see here, we removed the whole pannus from 360 degree from that affected eye. Fortunately, the fellow eye was not affected, so we are taking 2 conjunctival grafts from the fellow eye. This is the area where I am taking a limbus. So I've kept a little bit of conjunctiva which works as a handle for that area to get reflected. This is the area of the limbus. A very small amount of limbus is needed. The donor area is covered with the conjunctival graft. Now I've attached both the conjunctival grafts in the area where there was, symblepharon formation, and you can allow the rest of the conjunctiva to fall back. Once both the grafts are attached, you can put an amniotic membrane on the surface, which is also secured with the tissue adhesive. As you can see here, both the components of the tissue glue is applied. You secure it in the inferior fornix first, and then the other half is also fixed. Make sure that a very thin layer of glue is remaining. Bring in your limbal tissue, make it into small pieces, some 7 to 8 pieces, and you can arrange it in the form of 2 circles so that the epithelial growth comes from that, and you can apply both the components of fibrin glue. Make sure that it is well covered, and then you can put in a bandage contact lens, and we had put a tarsorrhaphy also. You can see that how well the eye looks after few months, and this patient has been stable over 4 to 5 years, and the eye is free, and his vision also has improved significantly from 638 part to 69 part. So these cases are very rewarding. This is another example where 35-year-old male sustained alpha.
1 minute.
Yeah. This is a 35-year-old male who sustained alkali injury, and after multiple procedures, he ultimately ended up with a localized. The primary aim of acute injury is to bring in some epithelialization, whether it is in the form of conjunctiva or a corneal epithelium. So here he developed a symblepharon formation in the inferior part. So he did not need any further, intervention in the upper part. But because it was, repeated symbleph formation, so we ended up doing a slat which is localized to the inferior part. And here we used a modification. We did not use the AMG into the central part. So this is known as a donut-shaped AMG to spare the central clear cornea in this case. And you can see in the extreme picture on your right side that the cornea has cleared so very well, and the fornix is also very well formed, and the eyeball is free, and the surface is quiet. This is another example, a 45-year-old male who was an industrialist dealing with some chemical powder, disinfectant powder, which fell in his eye 30 years back, and he was moving around from one place to the other with recurrent inflammations and was off and on steroids and lubricants. His left eye demonstrated large areas of limbal stem cell deficiency, sparing only 1 to 2 clock hours of limbus infratemporally, as you can see here in the clinical pictures, with pseudopterygium and pans from formation from nasal area reaching pupillary zone with superior and inferior arcuate area of stromal scarring. But there was no history of previous AMG. So you have to be careful, because these are the cases where your dissection should be careful, otherwise you can end up perforating the globe as well. And he underwent a slat and conjunctival autograft from the fellow eye, and you can see that the picture on your left side down is a donor eye from where we have taken 2 big conjunctival grafts covering the 360 degree of the affected eye, and we have taken a limbal tissue, and that pretty looks normal. And the other eye where the conjunctival autograft and his slat is done, that also looks much quieter, and the central area has also cleared up quite significantly, and the patient is asymptomatic.
So Dr. Boros, how many slides do you have still now?
Just I'll summarize.
Okay.
These are 2 examples of, this is an example of 360 degree LSCD, and you can see that slat has been done, and we did not do any conjunctival autograft, and the eye is doing very well. Post-slat procedure, if the corneal scarring is significant and hampers the visual function, one can also consider doing a dark or a PK based on the depth of the scar or a stromal involvement. And one can plan slat and dark or PK as either a sequential procedure or a simultaneous procedure. To summarize, many a times, like these patients need rehabilitation lifelong. As you can see here in this patient, he sustained ACID injury in 2009. He underwent bilateral AMG tenosplasty tarso multiple times, and then later on he underwent PK, penetrating keratoplasty and cataract and IOL, and the left eye still would need cataract surgery, and he still has small tarsorrhaphy, temporary tarsorrhaphy in both the eyes. You can see that he also lost his external ear. So these patients need a lot of care for a very long-term period. So to summarize, one can tailor the approach based on clinical involvement. For a successful outcomes, control of inflammation before any reconstructive procedure is a must. Techniques of limbal transplantation have evolved greatly over the last few decades. SLAT combines the advantages of both Clow and CLET and is simple, inexpensive, single-stage technique with improved anatomical and functional success, making it the technique of choice for limbal transplantation worldwide.
Excellent talk, Dr. Dr. Parosh. Now, Dr. Soham will be talking on late visual rehabilitation in bilateral ocular burn cases by different modalities of treatment.
Good afternoon, everyone. And most of my previous speakers have already covered. Thank you, Dr. Tuhin, for including me in this talk. So I'll be talking about late visual rehab in bilateral ocular burn cases. So very quickly, your clinical evaluation would decide the modality, be it conservative or the different kinds of surgical techniques that we have. So especially important to look at the lids and the fornix, extent and degree of the limbal stem cell deficiency, the corneal clarity, check and recheck the light perception, and in select cases maybe do some VEP also to confirm. So this is a new classification of LSCD that the international committees have come up with. So this also sort of helps in decision making. So to add on to what Dr. Pradhan said about the advanced imaging and diagnostics, if you have access to a confocal microscopy, that would again help you in diagnosing the level of LSCD. The things that we would look at is basically some of these inflammatory cells in the cornea, some of the conjunctival changes which is happening in the, which is what is anatomically supposed to be cornea, and also the destruction of the subbasal nerve plexuses. And also anterior segment OCT is again a very important tool which can help you in decision making. So if you have LSCD, poor vision of the cornea, you can always do ASOCT, see what the corneal thickness is and how the corneal reflectivity looks like. So then you can choose a good candidate for SLET. So between unilateral and bilateral cases, what is the difference? And also you can always go and try some late medical management. There is no harm trying, because some of these patients, might have some low-grade subclinical inflammation going on, so always a trial of anti-inflammatory agents might help in clearing up some of this corneal haze, maybe some reversal of corneal vascularization. There have been anecdotal reports about the neovessels disappearing completely with topical anti-VEGF drops. So that's something worth trying. And I'm a big fan of conservative management in these cases. So specialty lenses, definitely if there is some amount of clarity, if you are able to see the pupil, give it a try. So be it scleral lenses, there are these custom fit scleral lenses, or you can partner with LVP for having access to these Boston Pros lenses. So instead of going in for all these complicated surgical things, they actually give a very good visual outcome. And also there is a therapeutic benefit. So you can potentially delay the surgical surgeries later on. So surgery begins with taking care of the lid and the fornix. That is very important. So that's something which you might have to take help of your oculoplasty surgeons if you're not confident yourself. Broadly, two categories. It can be either a tissue transplant technique or a keratoplasty keratoprosthesis procedure. So tissue transplant aims at basically restoring some amount of limbal stem cell niche or taking care of some of this LSCD and conjunctivalization. Keratoplasty and keratoprosthesis would help in clearing the media. So this is a basic flow chart. So either a wet or a dry surface. Mostly in chemical injuries, they are wet surfaces, but sometimes in late stages, they might convert to a dry surface. So in wet surfaces, your options would be a Boston type 1 keratoprosthesis, limbal stem cell therapy, either a cultured or a simple, or an oral mucosal membrane therapy. So this is already dealt extensively by Dr. Paras, so I'll go over it. So what is different here is, in bilateral cases or unilateral monocular cases, you do not have a fellow eye as the donor. So you would either need a living related or an allogenic HLA matched or a cadaveric tissue. Cadaveric tissues don't tend to do very well, so living related is the best bet. But however, for all of them, a systemic immunosuppression is very important. So Dr. Ed Holland, again, is a very big proponent of KLAL, and he is also proposing a Cincinnati procedure, which is basically a combination of living related conjunctival limbal allograft combined with a keratolimbal allograft taken from a donor cornea. Clet and comet, again, for clet, it has to be not your own tissue, someone else. Comet is something which would be more useful here, but again, it needs that expertise from a lab, expensive time. So those are the three things. SLET has to be allo-SLET, cadaveric SLET. So again, the whole story of systemic immunosuppression and partnering with a medicine expert or a rheumatologist comes into the picture. Coming to keratoplasty, so it can either be a full or an anterior lamellar keratoplasty. However, it has to be staged after taking care of the LSCD first. These are the grafts which are definitely high risk, higher rates of failure, higher rates of rejection, so it needs more immunosuppression. Sometimes we even do like a dual topical immunosuppression, steroid plus tacrolimus or cyclosporin plus an oral immunosuppression. Adjunct procedures during keratoplasty is very important. They have shown some of very good case reports are there. So you can push some anti-VEGF subtenons or surrounding in the host cornea, do some vessel cautery either with a YAG or with a fine needle diathermy. Topical monoclonal antibodies, this is something people have been starting looking at it at the time of surgery. You are doing a keratoplasty, push some monoclonal antibodies, adalimumab or infliximab subtenons. They actually control that immediate postoperative inflammation. And adjunct use of amniotic membrane. So these would sort of improve the outcomes of your keratoplasty. And keratoprosthesis can either be taken up as a primary or a secondary. Secondary in the sense you have done a keratoplasty which has failed, then you go on to do a keratoprosthesis. But there are a lot of, Dr. Aldave's group has looked into the outcomes of doing a primary keratoprosthesis in these cases, and the outcomes are, they're actually recommending doing it as a primary keratoprosthesis. And the model and design of keratoprosthesis would depend again on the surface wetness and the lid anatomy. So if you don't have good surfaces, maybe a type 2 or something like an LVP K-Pro might be good in this situation. So this is someone with limbal stem cell deficiency, an optical keratoplasty was done, which has failed, now going in for a keratoprosthesis. So flaring currying, very important. Measure the graft. So once you have measured, then we mark it and then we start with the keratoprosthesis assembly. So I'll go over very quickly. So initially, this would be based on your size of the graft. So this is usually more than 8.5 millimeters, followed by a 3 millimeter central trephination is done. Now a type 1 keratoprosthesis has this optic with a stem. So this is 3 millimeter. And your 3 millimeter donut button fits in snugly. You make sure it is in place, and then which is followed by a back plate. So this is a pediatric back plate. So after the back plate is again pushed into position, then it is locked in with a titanium ring. So there are some differences in models. Some of them may or may not have a titanium ring. It's like a clip-on or a snap-on model. But that is sort of beyond the scope of this talk. So once your assembly is ready, rest is very much similar to doing a penetrating keratoplasty. Surgically, it's not so much difficult, especially if your initial management has been good. So we do that, do some trephination, put in a PMMA lens. So this can be a zero diopter, so your calculation for the K-Pro becomes easier. And then it is sutured in place with either a 10-0 or a 9-0 nylon. Finally, a large bandage contact lens is placed after rotating the sutures. So to conclude, managing bilateral LSCD is definitely challenging, it is expensive, needs multimodal approach, and you and the patient should be prepared for multiple interventions and often needs systemic immunosuppression. If possible, go for conservative methods, and surgery with adjuncts definitely will give better surgical outcomes. Probably in the future, we'll see more use of these stem cell therapies, the pluripotent stem cell therapies basically. Although it can be frustrating for both patient and the ophthalmologist, but we need to keep fighting. And I'll end with this. This is a very recent publication from the LBP group. This is known as SOMET. So you are applying the principles of SLET, but instead of taking tissue from the limbus, you're taking a small amount of tissue from the buccal mucosa. Then you chop it up into pieces, put it on the cornea, and basically you are doing a cultured oral mucosal transplant, but using the cornea as basically your growing substrate. Thank you very much. And we have the valedictory session next, so I think we can take questions later on.
Thank you, Soham, for excellent talk. So there is no time. If you have any questions, we can discuss at lunch area. So I can conclude this session. I thank all my co-instructors, Aditya Bajaj and Soham, for this course. Now I just hand over the session for these valedictory sessions. If you have any questions, we can talk on the way.